Hi everyone, welcome to this three-part episode of the Reflexology series on ischemic heart disease. We are very privileged to have Dr. Jieli, a cardiologist, to have a discussion with us. So today's first part will be about the immediate management of acute coronary syndrome. So maybe Shoban can start us off with the first question.
So Dr. Kwa, we just wanted to find out from you. I mean, when do we usually train the Trops? And I mean, like, when should we start doing Trops, or how long after a chest pain should we start doing Trops?
So I think Troponin there's a recent change in the Troponin that we use. So now we use high sensitive Troponin. And so the good thing about this Troponin is it's very sensitive. It's meant to pick up MI very early. For all patients presenting with chest pain that you're concerned about, definitely you should do one immediately.
Okay.
And there's quite good evidence in doing, so the recommendations is usually doing the second one at about 2 to 3 hours. Yeah, so I would say you can do one at the first presentation, the second one about 2 to 3 hours. And depending on your suspicion, if you are still very suspicious there's an MI, some of us may still do a third set, but actually with 2 sets is usually enough.
Sorry, the sensitive assays apply across most hospitals in Singapore currently already.
Yeah, so I mean, I can't say for the other hospitals, but I think it's being used everywhere. I mean, from when you get referrals from other hospitals, it seems that everyone's using high sensitive troponin now. And I think the guidelines also recommend to use high sensitive troponin. Yeah, so the other thing also I forgot is this trending till it comes down. I don't think it's really necessary. Most of us don't. I think it depends on clinician as well, but most of us don't do it. But I would say that one indication where you might really want to trend till it drops is myocarditis, because you want to make sure that the patient there's no ongoing inflammation of the myocardium. So that might be one indication where you really have to trend it till it comes down. But most of the cases, the NSTEMIs come in, the Trop shows a clear rise, you send the patient for cath post-PCI. I don't think most of us will do another set just to see it come down.
So you mentioned that in patients who come in, have a rise in Trop, and then you go for NSTEMI, and you go NSTEMI or STEMI, they go for PCI, don't need to do. But what about those people who you are treating medically? Do you continue to train the Trop to sort of prognosticate, or there's no need once you clean the diagnosis of STEMI and non-STEMI?
Personally, for myself, I wouldn't, because if I'm going to treat the patient medically, it doesn't really give me much information. I agree that the magnitude of troponin does, there is some prognostication to that, but at the end of the day, if the patient has already decided to go for medical therapy, then I don't see how the information is going to be useful to me. And it's just going to add more cost to do another blood test. So I don't think I will usually do it.
Okay, got it. The next question is there a role still for CK and CKMB with the very sensitive assays that we have for troponins?
Yeah, so the answer is no. It's been taken out, and I think in the guidelines it says it's a class 3 indication to do CK and CKMB.
Okay.
So we don't do it anymore.
Okay, the next question is about, so I mean, most of us are very familiar that if there's a clear-cut ST elevation on the ECG, we'll call cardio activate cath lab. But are there any equivalents that would require such urgent action, but may not manifest as ST elevations on the ECG?
Yeah, so I think there's quite a few ECG patterns that as cardiologists we're usually more worried about. So the first one is what we call the De Winter's ECG, right? And then the second one and the third one are actually different kinds of Wellens. So I think for this kind of patients, in the right clinical context, meaning that they come in with chest pain, we're always worried about proximal LED occlusion. May not be 100% occlusion, maybe a very tight LED, but in this kind of situation, we would still prefer to bring the patient to the lab early. Then left bundle branch block, as we all know, is another indication of an anterior STEMI, but it has to be taken in the right clinical context as well, because you have a lot of elderly patients who have degenerative left bundle branch block ECGs, and it has been there for years. So even if they come in with chest pain, sometimes it's not really a STEMI equivalent. So like they come in with a fall, for example, and then they have LBBB. It doesn't mean that it's a STEMI equivalent, but in the right clinical context, LBBB is also another STEMI equivalent. And then the third, so all these ECGs are pulled from the internet. I hope I'm not infringing any copyright stuff. But this third ECG is an interesting one because you can tell that there's USC elevation. This is a It's a giveaway. There is a right. This is a right-sided ECG because you can see ST elevation of V4 to V6. They numbered it so you know that it's not a normal V4, V5, V6. There is no RAs there. That's why you also know it's not a normal V4, V5, V6. So this is a right-sided ECG.
Okay.
So there's inferior with RV involvement. And I think the interesting bit is the V1 to 3 showing very horizontal ST depression. That's suggestive of a posterior STEMI. So I think posterior STEMIs are something that we miss quite often as well.
Okay.
Another sign that you may think of posterior STEMIs if your V1 is a little bit, the R wave is tall. So usually V1, the R wave should be short, right? But if it starts to get taller and taller, it's equivalent of a Q wave, like we see opposite. That's why your R wave gets taller. Like when you have evolving STEMIs, you get deeper and deeper Q wave, right? So your R wave is kind of a reflection of that. So that's another, I mean, it is a STEMI, it's not really a STEMI equivalent, but it's just something to look out for.
Yeah, got it. Thanks.
Yeah, so I think this one is quite straightforward. I mean, not all NSTEMIs demonstrate ECG changes. You have a lot of patients who just have chest pain and raised troponin, right? And you know that definition of MI is 2 out of 3 on symptoms, ECG changes, and troponin. So you don't necessarily have to have ECG changes. Yeah.
Okay.
So is MONA still relevant in this day and age, especially the morphine and the oxygen component of things?
Yeah. So I think like you said correctly, morphine and oxygen is not really part of the initial management. For morphine, there's suggestion that it may interact with your P2Y12 inhibitor, so it's actually discouraged. But obviously, if the patient has very, very bad chest pain, then we would still give it, but not routinely. Then for oxygen, I think there was some data suggesting that it may worsen outcome. So it's more of if patients have low, you only give it if they have low oxygenation. Yeah. So this MONA thing is not very ethical. And then for nitrates, of course, we know that for inferior MIs and stuff like that, it's not a good idea to give them nitrates.
Okay, Ken. The next question I think that many residents have is the choice of second antiplatelet agent in different contexts. So we know there's Cervix, ticagrelor, and Captopril. So when do we give which agent?
Yeah, so I'll just put a summary of the trials that were done. So for ticagrelor, it was the Plato trial. So basically what happened in the trial was there's at least 10,000 patients, and ticagrelor showed that it has less cardiovascular outcomes compared to clopidogrel with no increase in overall major bleeding. And I think one of the important points in this trial is also it can be used in people who are treated medically. So meaning patients who don't want to go for intervention, you can give them ticagrelor. Okay. Right. The second trial is a Triton trial, which is looking at prasugrel. So again, in terms of cardiovascular outcomes, prasugrel was better than clopidogrel, but it showed that there was increased risk of major bleeding. And then two important points about prasugrel is they only give it after the angiogram. So they don't give it. So most of the time we actually load patients pre-angiogram, but in the trial they did it after they saw the angiogram now. Okay. So I think the reason is because in case a patient is going to be a bypass patient, for example, then you don't want to continue prasugrel. So that is one of the caveats of the trial. The other thing is there are quite a few contraindications to using prasugrel. So if you have a history of stroke, if you are elderly, age more than 75, or if you have a body weight less than 60 kg, then you shouldn't use prasugrel. So this is just a quick summary of the two trials. And then there was a recent trial done in the last 1 to 2 years where they compared prasugrel to ticagrelor. So it's a much smaller trial. I think it's just a few thousand. It actually showed that prasugrel showed a little less, a bit better compared to actually it's a typo, is compared to ticagrelor, not clopidogrel. So it's a head-to-head trial between prasugrel and ticagrelor. Yeah. So putting all these trials, to summarize all these trials, I think almost all hospitals still use ticagrelor more because firstly, prasugrel is more troublesome.
Yeah.
That recent trial that came out, it didn't quite pick up. I think people still kind of feel that it was a bit underpowered, so we still kind of trust ticagrelor more. So by default, for all ACS patients, you should use ticagrelor. Clopidogrel is more for patients with stable elective PCI patients. And then, of course, if there's any concern about bleeding risk, if the patient, whether it's pertaining to the patient or whether you're going to use it with warfarin or NOAC, then clopidogrel is also given preference. And the last is of course cost issue. So some patients find that ticagrelor is quite expensive. So some of us may even just give like 1 month of ticagrelor and then change it to clopidogrel. There is some evidence for that as well.
Okay. So in the acute setting, the take-home message most of the time would be ticagrelor, unless mainly the bleeding risk part, if there's anything to suspect that, then you may consider clopidogrel.
Yeah, so for ACS, ticagrelor.
Okay.
So the next thing I asked, basically, you see some patients with anticoagulation after ACS. Just wondering what are the indications for anticoagulation in ACS?
I'm guessing the anticoagulation people are talking about is taxane, right?
Yeah.
Not, yeah. So I think in all patients with NSTEMIs, real NSTEMIs, not like type 2 MIs, they should be given taxane, but taxane is also, I mean, because of there's always this concern about bleeding risk in our local population. So I would say that in someone who's more elderly, I would prefer not to. So in someone who's quite young, I would definitely give taxane. The other reason that would push me more or less towards taxane is if a patient comes in during the weekend and I know he's not going to get his PCI over the next 24 hours, then I'll prefer to keep the patient on taxane as well. So all patients should still ideally be on DAPT and taxane. The other thing to note is you shouldn't give it to, let's say you're cutting the patient at 3 a.m. or 4 a.m.
Yeah.
And you know that he's definitely going to get a cath the next day, and then try not to give the taxane at that time, because usually need at least a 6-hour window period before he goes for his procedure. Yeah.
Okay. And in patients with renal dysfunction, do we then give heparin or taxane?
Yeah, so renal impairment is another difficult one. I would say most of us would give it once a day.
Okay.
But probably it depends on how bad the renal function is. Like obviously end-stage renal failure, you should be a bit more cautious. Yeah, I don't think any of us would order IV heparin or.
So the next question is, when do patients with NSTEMI require emergent revascularization?
So for NSTEMIs, there are few reasons why we bring them to the cath lab quite fast. So one is if they have ongoing chest pain. So typical chest pain, not because sometimes you get referrals for patients with like reflux pain and it says ongoing chest pain, but this is in the context of NSTEMI. So NSTEMI with ongoing chest pain, we bring them to the lab. Is a good thing to know that a lot of times actually circumflex STEMIs, they may not have typical ST elevations. So a lot of these NSTEMIs with ongoing chest pains actually turn out to be a 100% circumflex occlusion. Other indications, if a patient has ongoing ischemia triggering heart failure, for example, that is a reason why we may bring to the cath lab. And for patients with ventricular arrhythmias as well, if a patient has VT or VF and then after you shock them, especially if they have SC elevation after you shock them, then we'll bring them to the lab. Yeah, there was a recent trial as well that showed that patients with ventricular arrhythmias after you shock them, whether there's benefit in bringing them to the lab immediately. I think that was a negative trial, but I think most of us would still activate the cath lab if we do see a patient with a ventricular arrhythmia. This TIMI Grace thing, I don't think any of us really use it.
Yeah, next thing I ask is like when do we or which patient population will require like telemetry monitoring? Is it everybody with ACS or is it just certain populations?
Yeah, so I would say that every patient with that you suspect is acute coronary syndrome should get telemetry monitoring because you require continuous cardiac monitoring.
For how long should they be monitored?
Until they get revascularized.
Okay.
What about the unstable anginas with no Trop rise? For these patients, do you normally get a telemetry bed for them too?
Yeah, so unstable angina, I think, is a diagnosis that is made in epidemic proportions because everyone who has new chest pain is labeled as unstable angina, right?
Yeah.
So that's the first thing. The second thing is actually given how highly sensitive troponin is nowadays, there are very few patients with unstable angina that have a normal troponin.
Okay.
So but if you are convinced that a patient really has symptoms that are very typical of unstable angina, and they have ECG changes, again, that will support the diagnosis, then I will still put these patients on telemetry monitoring.
Okay, thank you. The next question is more of a practical question for probably the doctors, the junior doctors in CCU and stuff like that. What should be things that we should be looking out for post PCI?
So assuming that your intervention is successful and interventionist didn't put anything funny in the report, like there was a perf or there was a dissection, for example, then I think the main thing is always vascular complications. We are always very particular about that, especially from femoral access. Yeah, so that is the main thing, and usually they happen within the first 6 hours. So that there is a very important window to keep an eye on these patients. Yeah, so vascular complications is the most important thing. I guess from a resident's point of view, probably you see a lot of patients with STEMIs who come back to the CCU, and sometimes still have a bit of chest pain, sometimes still have a bit of ST elevation. I think the important bit is they shouldn't be worse than before. So if the ST is even higher than what they came in with, then there would be something worrying. A lot of times the STs may take a while to come down, but even if it's still elevated but it's getting better, I don't think that should be what we're concerned with. I've seen a few patients with stent thrombosis that come in immediately after PCI, but that is very, very rare. But if it does happen, then it's one of those things that you will never forget, because the patient comes back in, it's like clutching his chest, it's very severe chest pain. Maybe other things are things like heart failure, because a lot of patients, they have an MI and then they kind of go into heart failure. A lot of times during the cath, we give them fluids to bring up their blood pressure and things like that. So when they come back to the CCU, they end up having to be put on oxygen. So be mindful that maybe going to failure. So always make sure you auscultate their lungs, make sure that they don't need furosemide. And maybe one of the other things that may not be so apparent is in primary activations, the interventionist doesn't have information about the lab test. So maybe some patients actually have chronic kidney disease and they actually went a cath. So if you do see that a patient has CKD, then just be mindful that it might be helpful to put them on intravenous hydration to kind of help with the risk of contrast-induced nephropathy. Yeah. Because we might not put it in the notes because the results is just not out yet.
Next thing that I ask is regarding type 2 MIs versus Trop leaks. So is there what's the difference between a type 2 MI and a Trop leak? And how do we go about managing people with type 2 MI?
So the definition of MI is a rise and fall in cardiac enzymes. Right? So if you are to label someone as a type 2 MI, it must be clear that it is a MI. And it is due to a supply-demand mismatch. So I think type 2 MIs, firstly, already is a diagnosis that is quite often overdiagnosed. A lot of times you have patients with sepsis or even strokes or different reasons. They come in with raised troponin, but it doesn't show a rise and fall, and then we kind of label it as a type 2 MI. So we'll be clear what we are labeling as a type 2 MI. And the management of type 2 MI is you manage the underlying cause. Whether we are going to treat them like a type 1 MI, nobody really knows, but I think what they usually advise is based on the overall patient profile as well. If you think this patient is obviously going to have high cardiovascular risks, then it may be more evidence to kind of manage them like a type 1 MI as well. But you have to remember that a lot of these patients have a high bleeding risk. So I tend not to put these patients on antiplatelets. When I see someone with a type 2 MI, for me, the main thing is after the event, what am I going to do for the patient? Am I going to work him up for ischemic heart disease that's causing the type 2 MI? So the acute management part, I don't think is right to kind of to just load them on DAPT and this without thinking through. This troponin leak is something that I don't use. So I'm not very sure why people sometimes label it as that. But if you look at the MI consensus document, they call it myocardial injury. So if you don't have a rise and fall in enzyme, and then you kind of have like a troponin that's quite high, but and it's kind of like up down, then you can say there's myocardial injury from these various causes. Yeah, but I don't like to call it troponin leak because sounds very non-medical. It sounds like someone is having some prostate problem and then it's like sounds a bit funny. Yeah, so I usually say myocardial injury. Yeah, so I think troponin is being used more like a screening tool because we are doing it for all sorts of patients coming with constipation also get troponin. I'm not sure how a cardiologist is supposed to interpret that. So I think it's important to do it in the right clinical context. Yeah, we have to be mindful of cause issues to patients as well. We just send off every blood test. Yeah. Okay. So in summary, I think type 2 MI, be mindful of the rise and fall in enzymes before you label it as a type 2 MI. Management-wise, whether you're going to give DAPT, I think there's no clear consensus on that. But I think it's important to think about what you're going to do for the patient after the initial episode, whether you need to work them up with a perfusion test or whether you're going to work them up with an angiogram. I think that's more important.
And for those with myocardial injury also, we also tend to evaluate them in that same vein as for the type 2 MIs?
So again, I think it depends on the overall situation. Like if the enzyme is very high, then that might push me towards working out the patient more. A lot of times the patients get echo anyway. If the echo shows regional wall motion abnormality or low EF, low systolic function, then again that might push me more towards. Of course, taking the talking to the patient. If the patient obviously has angina even before these things, then of course then you work him out for ischemic heart disease.
Okay. Do you have any take-home points or final messages for the immediate management of ACS for the residents and junior doctors?
For the real ACS patients, obviously you only see the real ACS patients when you come to cardiology. So aspirin, so do antiplatelet therapy is of course important. So aspirin and like I said just now, usually ticagrelor, the second agent. High dose statins, so don't be scared to load them on 40 milligrams of atorvastatin. And I would say beta blockers is important upfront as well because a lot of times these patients come in with MI, you need to reduce their ischemic burden. So you try to slow the heart rate down with beta blocker, you give them nitrates upfront as well. These are the main components of the initial management. Yeah. And then to look out for things that you might need to call your registrar for, whether the patient has ongoing chest pain, whether there's those ECG STEMI equivalent patterns that you see, then you might need to alert your registrar early as well.
Okay, thank you.